cooperation in evil is a problem for all of us, affecting many areas of our lives. It's a particular problem for those who work in healthcare, above all in the reproductive area. Sometimes it's easy to work out the right thing to do, even if very hard to do it. Other times, however, it may be much more difficult to work out how close to get to others' wrongdoing and strike a balance between being too strict or perhaps more likely not strict enough. It's often a good idea to get a second opinion, both when getting advice and when giving advice, as there are many cooperation questions on which even experts disagree. The good news is that there are certainly agreed general principles in the area of cooperation. Starting out with these, we can try and work out logically how they might apply to problem cases. So, what are the principles? The most important distinction is between formal cooperation and material cooperation. You should all have a copy of the handout. There are lots more if you need them. Material cooperation in evil is doing what, in effect, helps someone do wrong and or gives the impression of condoning it, but without sharing the precise wrong-making intentions of the main wrongdoer. Material cooperation is sometimes right and sometimes wrong. Indeed, it can be very wrong due to the effects it may have on the cooperator and or other people who may be badly harmed or confused. Other times, however, cooperation of a material kind may be justified due to its remoteness and or the goods at stake, especially if the evil in question is in any case likely to occur. Examples might be when a taxpayer helps to fund abortions without intending this in any way, or a bus driver stops at all his stops, including outside abortion clinics or other sites of unjust killing, such as labs where IVF embryos are destroyed. So, moving on from material cooperation, to which we will, however, return, what is formal cooperation in the wrongdoing of other people? Formal cooperation is always morally wrong. It occurs when the person cooperating shares some wrong-making intention with the main wrongdoer, or deliberately endorses some wrongful choice that other person makes. That it's wrong not just to do abortions, imagining I'm a doctor, which sadly I'm not, but to arrange deliberately that my colleague do them instead. If it is wrong to do an abortion myself, it is also wrong to get someone else to do one. In fact, it is worse to get someone else involved, as two people are then corrupted, not just one. Neither I nor my colleague is a cog in a machine. We are both moral agents with responsibilities, and I should not use my colleague to do my dirty work for me, so to speak. Let's imagine that I'm a doctor whose patient has just asked for an abortion. I might perhaps mention, as I try to encourage my patient sympathetically to think again about having her baby, that she has a legal right or institutional right to seek a second opinion from a doctor of her choice. That may be something I need to mention to my patient to cover myself with my employer or regulatory body, so as to go on practicing as a doctor and helping patients as best I can. It may also be something that helps calm things down. My patient may be more likely to hear what I have to say about support to have her baby if she does not feel actively obstructed from pursuing what may be a standard procedure, sadly, in the country where we live. In contrast, it is very different morally to tell my patient to go and find a pro-abortion doctor. Or worse, tell her exactly who to go to, my abortionist colleague down the hall. If I do something like that, I am intending that she go to, or at least that she decide to look for, a pro-abortion doctor, precisely as a means of getting an abortion. I am deliberately, formally cooperating in my patient's abortion-seeking behaviour, if only as a way of getting her out of my office and getting myself out of an awkward situation. I'm in short intending that my patient try, or decide to try, to get an abortion elsewhere. This is letting my patient down badly, to say nothing of her baby and the doctor, perhaps an unknown doctor in a clinic, to whom I send them both. Instead, if the woman asks me where to go for an abortion, I might explain that she is of course free if she wishes to get a second opinion from a doctor of her choice. It is entirely up to her who she consults, I might say, for a second opinion if she thinks that necessary. In any case, I hope she'll understand that I will not feel comfortable helping her find someone else prepared to give her something which I believe, as her doctor, is not in her best interests, but will do her harm. That would be hypocritical, I might say. Why would I deliberately help her get something I think is not in her best interests? Depending on her reaction, I could then say that this is obviously an important decision to make, which of course it is, and that the patient may wish to think about it further and perhaps discuss it with her family. I might perhaps hand her as she leaves, or invite her to pick up for herself, a card for an organisation offering pregnancy support, and say she is welcome to come back to me any time, including if she does go ahead with the abortion and has problems afterwards. I'm sure many people in this room will have their own good ways of dealing with this kind of situation. In fact, we've just heard a particularly good way from the Hassans just now. I mentioned earlier that it is wrong even for the woman to plan to get an abortion elsewhere, and therefore wrong for me to intend the woman form that plan. Preparing to do something morally wrong, or deliberately helping someone else prepare to do something morally wrong, is itself morally wrong, just like doing the wrong thing for which we are preparing. If I decide to be a mugger, for example, it's wrong not just for me to rob people at knife point, but for me to buy a knife and lie in wait in suitable dark corners. It's also wrong for someone to deliberately help me do this, say by selling me the knife for that very purpose, or telling me about good mugging areas in the neighbourhood, or possible partners in crime. Similarly, if abortion is in fact wrongful homicide, as of course we believe it is, all deliberate preparation for abortion will also be wrong, and should not be promoted qua preparation. Acting wrongly is not, we should remember, the same as being culpable. My pro-abortion colleague down the hallway may not be particularly culpable for his choices in this area, depending on his personal background and awareness of what he is really doing. Nonetheless, if I actually intend that he act in a way I at least know is seriously wrong, my own act in sending my patient to him is also seriously wrong, and I may be far more culpable than he is. What are some other cooperation problems that can arise in reproductive medicine? Such problems may arise in the course of responding to fertility problems. For example, in a country where many women or couples are seeking treatment will not be married, or will be in invalid second marriages. Again, if I'm a doctor, I may well be tempted to help an unmarried couple to conceive naturally, if only to avoid the couple pursuing IVF, with all that means in terms of embryos discarded. My motive here is of course very good, but good motives are not enough. Here as elsewhere, all my intentions must be morally right, for my action to be morally right. So if I deliberately assist the couple to find a good day to conceive when the woman is more likely to be fertile, I'm cooperating in their wrongful sexual act plus their wrongful choice to conceive. To repeat, wrongful is not the same as culpable. The couple may be in complete good faith here, but that does not make what they're doing in conceiving outside marriage morally right. So what should I tell the couple in explaining why I cannot help them with day-to-day premarital conception choices? may depend on what country I live in and what attitude my regulatory body takes. In some countries, it may work for the doctor to cite, in a sensitive manner, the best interests of the child, pointing out that research shows overwhelmingly that children do better with married parents, not least because unmarried parents so often split up before the children have grown up. In other countries, however, the doctor may need to be very discreet and tactful in dealing with these situations, as the law and/or regulatory body may prohibit what it sees as discrimination on the basis of marital status. In that situation, it may be wise for the doctor to link him or herself to some other body or network with a code of ethics and/or ethical advisors to refer to, and explain that patients are only accepted onto the fertility program after a written application process. Any such written application process should include, in the course of getting patient details, detailed information on the patient's past and present marital status to avoid problems down the line. The doctor might explain that because of conscientious objections of people working on the program, which need to be respected, unmarried patients are not, in practice, accepted onto the waiting list unless they are planning on getting married. If the couple are planning on getting married or thinking about getting married in any case, they are most welcome to apply, although the doctor might say he can't promise they'll be accepted. And in any case, day-to-day help to conceive, as opposed to background information and investigations, will begin once the wedding bells have actually rung. Of course, the doctor can still try to discourage the patient gently from IVF, pointing out that it is a very stressful procedure with lots of ethical problems. Potentially, the doctor could offer to investigate and/or treat structural causes of infertility, such as blocked tubes, including after sterilizations, as opposed to collaborating with day-to-day acts aimed at conception here and now. This would be wrongful cooperation in the couple's immediate wrongful plans. Someone who has had her sterilisation reversed is now more healthy, whether or not she then goes on to conceive. And a doctor who reverses her sterilisation may well be justified, even if there is some unintentional material cooperation with the patient's aim of conceiving as soon as possible. The doctor's aim may be firstly the patient's long-term health, and secondly conception at some later suitable time, bearing in mind that a permanent reversal of infertility, unlike help to conceive on a day-to-day basis, will still be effective in the future when the patient may be married and perfectly justified in conceiving. Now, of course, I do realise that natural family planning is a school for life, and the skills that you learn from your NFP instructor you can use when you actually do get married. But I was talking about the choice, to conceive now. This is a good day for you, try today, that kind of choice. Of course, it goes without saying that any refusal to help the couple seek conception in the long-term future should be made in a kind and courteous way, bearing in mind that the couple may be in perfectly good faith in trying to conceive outside marriage, let alone in an invalid marriage that they may not realise is anything of the kind. One common but still non-standard form of cooperation in evil that can sometimes cause problems is perhaps better called appropriation of evil, or being an accessory after the fact. An example might be a medical researcher who works with fetal tissue obtained from abortions. Even if the researcher does not intend that abortions take place, as he may well intend, especially if he needs them done in a certain way, it will be difficult for him not to give the impression he accepts abortion if he is prepared to work with fetuses obtained directly or just one remove from those who bring about their deaths. What What should we say about a researcher who does not himself work on aborted fetuses, but uses a cell line or the product of a cell line originally derived from an aborted fetus? In trying to establish whether or not material cooperation in such cases is morally justified, we need to compare the reasons for cooperating with those for not cooperating. Refusal to cooperate materially may have unfortunate consequences in, for example, putting lives at risk and or closing off some avenue of research which could serve the common good. On the other hand, cooperating even remotely in an unjust procedure may harm us to begin with, in that it may make us less sensitive to the wrong involved in that procedure. It may also harm other people, in that it may give them the impression that the wrong concerned is not, after all, so very wrong in our eyes. The greater the risk of corrupting ourselves or of giving the impression to others that we have no strong objection to some wrongful procedure, the more serious needs to be the reason for doing what facilitates or seems to condone that procedure. The desire to pursue a promising line of research is not an adequate reason to use fetal tissue obtained from an abortionist, or indeed from a go-between, as would normally be the case. In the same way, in contrast, making use oneself of results already published in a journal is less likely to give the impression that one has no problem with the destruction of embryonic lives. In the same way, using a cell line originating decades ago in an aborted fetus is less likely to give the impression that one regards abortion as morally acceptable than was the original use of fetal tissue. This is rather like the difference between buying something direct from a thief or receiver of stolen goods and buying it in the market, when you can see it must have been originally stolen, though it can't now be returned to the original owner. Having said this, there can be a place for refusing even remote cooperation with a past evil, where this seems likely to give effective witness against similar ongoing evil. Are there ways of health professionals heading off some of the problems they may face? Yes, there are, beginning with job applicants letting prospective colleagues know their position before starting, if not before getting the job, which is often, if not always, a good idea. Obviously, in applying for jobs, the applicant will want, first of all, to win the confidence of the panel as a good person to work with, establishing rapport in areas of common interest. It is better not to assume hostility, but rather to invite prospective colleagues to agree that they would not wish to put one in a difficult situation by asking one to act against one's conscience. Applicants could stress that they are aware that many patients take a different view from them on some issues, that they realise that they are in practice free to act on that view, and that in any case they think it important patients be spoken to in a respectful and considerate manner. Such points can also be made by established health professionals who want to make changes in the way they do their work, bearing in mind that colleagues may tolerate such changes in someone they have come to know and respect. Taking a stronger moral line may not be as difficult as one fears. Conscientious objectors should always bear in mind the distinction between, on the one hand, reporting to a supervisor one's inability to do what's expected, and on the other hand, deliberately getting the supervisor or some other colleague to do exactly what is wrong. Telling my boss that I cannot do or arrange abortions is not the same as asking my boss to do them for me. If things go badly despite one's best efforts, or if one needs advice in advance, help is available from organisations like the Anscombe Centre, or indeed some pro-life or pro-life legal organisations which can provide support. Why does all of this matter so much, we might ask ourselves, in these situations? Even at a natural level, it matters more than anything else what kind of people we become. We are not what we eat, or not only what we eat, but what we choose. While it may be desirable or even a duty to save our jobs and careers if we can, There are certain things we simply cannot choose, as they make us genuinely complicit in evil. Failure to remember this harms not just our patients, but our own moral characters. As these are serious matters, our very souls may be at stake. On the other hand, we can be over-scrupulous, and this danger too must be avoided, as it will make us less productive and less helpful to others than we should be. Mike Delaney makes the point that if we refuse to tolerate acceptable levels of material cooperation, we sin by omission, in that we're not contributing our God-given talents or helping to redeem the practice of medicine or healthcare. The aim is clearly to pursue one's vocation to the best of one's ability, while avoiding all wrongful cooperation, whether formal, i.e. intentional, or scandalously close material cooperation. Doing this successfully may require forward planning as well as courage and commitment. It may, in short, like so much else, require the wisdom of the serpent as well as the innocence of the dove.